get started. Looks like we got quite a few participants here. So my name is Dr. Alex Pavidapha. I have a little intro slide here about myself. And let's see. So I work at hemorrhoid centers in Northern Virginia. I did most of my training back in Massachusetts, moved down here for this job where I'm heavily focused on high-end embolization, which hemorrhoid artery embolization, which I'll go into details tonight, is a procedure that falls under that category. So this is just kind of awards that we've gotten for our work here. I have a slide later in the deck here, but this past October, we got, or October 2023, we got an award for outstanding research in GI bleed for hemorrhoid artery embolization from the American College of Gastroenterology, which is not the society that we're involved in. So to get an award from an outside society for what you do is pretty important. And then we also got an award this year for most outstanding abstract this year from our own society at Society of Interventional Radiology for hemorrhoid artery embolization. So to kind of take a step back, so what is interventional radiology? So essentially it's a medical subspecialty where we use image guidance. So we take the radiology portion, which is basically acquiring images to diagnose, and then taking it a step further to implement some type of treatment to treat different diseases or diagnose different diseases. And they typically have less risk, less recovery time than an open surgery or traditional treatments that have been done in the past. So background on what the topic is for tonight, which is hemorrhoids. So why are we talking about this? Because it's important and it's very prevalent throughout the world, but especially in the United States. So 4 to 5% of the general population each year get diagnosed with hemorrhoids. Peak age is somewhere between 45 and 65 years old, but I treat patients as young as in their 20s, as old in their 80s or 90s. So there's no necessarily like age cutoff. Up to 10% of patients will require surgical treatment, and I'll kind of go into which type of patients those tend to be. And then typically there's no sex preference except in young pregnant females. They're predisposed to hemorrhoids. So just a little further introduction here. So hemorrhoids were the third most common outpatient GI diagnosis, with nearly 4 million office and emergency room visits annually. There was a research study done in 2014 out of Chapel Hill, where it said hemorrhoids accounted for up to $700 million, or over $700 million, I think $760 million in cost to the healthcare system, whether it's prescription medications, time off of work, procedures, office visits, emergency visits. So there's a high cost to the medical system. There's multiple treatment options. So this is kind of going some type of more invasive, the least invasive, except hemorrhoid artery embolization is one of the minimally invasive, but lifestyle modification, obviously, if you're not doing any type of procedure that's not invasive at all, those type of things would be encouraging good bowel habits. It can be something simple like changing your diet, also certain topical medications or over-the-counter medications. You may or may not have heard of rubber band ligation, which is an office-based procedure where they basically treat the hemorrhoids that way. I'll go into a little bit more detail, but essentially they're going to strangulate the tissue and try and get rid of it that way. Hemorrhoid artery ligation, which is kind of the grandparent or the forefather of what the procedure is that we do, and kind of the premise that we based our procedure off of. Sclerotherapy, which is not done as frequently now. There's other procedures in between, and then there's hemorrhoidectomy, which is the surgery where they'll cut out the tissue and tie off the blood vessels. And then hemorrhoid artery embolization, which is the procedure that we offer, and I'll go into a little bit more detail. So this cartoon over here on the left-hand side, it's kind of giving you two different things here. One's an anatomy picture. I don't know if you can see my mouse, but that's the area where the hemorrhoidal tissue occurs. And actually hemorrhoidal tissue is normal. So they're basically these fibrovascular cushions made of blood vessels and connective tissue that basically serve as bumpers to help aid in fecal continence or keeping stool inside the body when it's supposed to stay inside the body by helping maintain the rectal tone. There's usually three tiers of blood supply. So on the sides of the image on the left, you can see three different levels of blood supply. So it's superior rectal, middle rectal, and inferior rectal. Now, typically when we're doing our procedure, we treat the superior middle rectal arteries, and I'll kind of go into that a little bit more detail. But just in general, the pathophysiology of how this happens or what ends up happening and why there's an abnormality has to do with these blood vessels getting out of whack and getting too large and too much pressure increased. And now on the screen right here, it's basically a grading system which we use to grade internal hemorrhoids. So that's what we're talking about. So grade 1 will be symptomatic hemorrhoids like bleeding, pain, discomfort without necessarily any prolapse or the hemorrhoid sticking out. Grade 2 would be prolapse of those hemorrhoids, symptomatic hemorrhoids, but they would reduce or go back up into the canal spontaneously without having to be pushed back in or reduced. Grade 3 would be where the hemorrhoids protrude out, but they won't go back in on their own, or they typically don't go back on their own, and they have to be pushed up and reduced manually. And grade 4 would be they can no longer be reduced. And when I talked about 10% of surgery may require surgery, those are typically reserved for grade 4. So typically the procedure that we're doing this for is somewhere between grade 1 through grade 3, but there are occasions where we will treat grade 4. So risk factors, we kind of touched on it a little bit. So anything that increases your intra-abdominal pressure. So pregnancy, we mentioned, is one of them. Poor bowel habits. So it's not uncommon today, but sitting on the toilet for too long. So really anything longer than 5 minutes where you just really should be doing your business and get out of here. So iPhone, iPad, newspaper, magazine, what have you, is all detrimental to good bowel habits. Straining too much to go to the bathroom, chronic constipation, chronic diarrhea, low fiber diet, insufficient fluid intake, obesity, sedentary lifestyle, all can contribute to having internal hemorrhoids or symptomatic internal hemorrhoids. So treatment options. So I touched on a few of these. So on the screen left here, this is the surgical option or hemorrhoidectomy, where they're going to cut out the tissue. But as they do so, you can see a suture here. They're going to tie off those abnormal blood vessels, like I talked about. So you can imagine. So what's most commonly done for hemorrhoids is what's in the bottom right here, which is rubber band ligation. So here they're using a forceps. They may not use a forceps. They may use like a vacuum, but basically they grab that tissue and they have this rubber band. They pop this rubber band on there. The idea is the rubber band strangulates so tightly, the tissue eventually sloughs off, dies. There's a small wound. The wound heals, and symptoms improve. So it typically works somewhere between 65 and 90% of the time, but recurrence rate can be relatively high, upwards of 49%. So the largest study done on hemorrhoids was comparing this procedure, the rubber band ligation, to the one at the top, which you see looks like that spaceship looking thing. And recurrence rates with the rubber band ligation was upwards of 49% at 12 months. And you can kind of imagine why, because if you're just grabbing the tissue indiscriminately, you're not actually addressing the root cause or the source of the problem, which are those abnormal blood vessels now that are still going to be perfusing that area. So that's why the recurrence rates are so high. Surgery, the recurrence rates are going to be much lower. Success rates are going to be much higher because you are cutting out the tissue and then you're going to tie off those blood vessels. So the recurrence rates will be lower, but it's a surgery. So there's obviously more risk involved. And if you've ever known anyone who underwent this surgery, it's pretty painful and prolonged recovery. You can't really rest this area. You still have to go to the bathroom. You still have to sit, still have to sleep, and it can be pretty painful. So in the top right is what's called Doppler guided ligation. So that is, like I said, kind of the grandfather of the procedure that we do. So what they did there, and this is done more in Europe, it's not really done much in the United States as much now, but in Europe they still do it. But basically they're using a Doppler, which is a device to help find the blood vessels. So it's targeting the blood vessels and putting a stitch around it. So cutting off the blood flow or the abnormal blood flow to that area. And they found that they had better primary success rates and lower recurrence rates than rubber band ligation. We talked about medical management. So it's always good practice, because even whatever treatment you have, if you do have a flare up, which can happen with any of the treatments, keeping this in mind and having this in your back pocket, stool softeners or low dose laxatives, like a gentle laxative like Miralax, is always safe to take. It's safe for babies to take for prolonged periods of time, so it's safe for adults. Bowel habits, so avoid straining, sitting on the toilet for long periods of time. Sitz baths, which that's what this kind of cowboy hat thing is over here on the right hand side. Preparation age and topical steroids or suppositories definitely can help in the short term. I would advise patients to not use it for prolonged periods of time, because it actually, so steroids on the tissue can actually thin the tissue and worsen symptoms over time. It's good for the acute flare-up because it will help with the inflammation, but if you take it for a prolonged period of time, it can actually make symptoms worse by thinning the tissue and causing bleeding. Washing aggressively with soap can dry the mucosa and tissue and make symptoms worse over time. It's kind of counterintuitive, because oftentimes you have issues with hygiene when you have prolapsing hemorrhoids, but this tissue isn't the same as, like, say, the tissue on your skin. This tissue is actually meant to be inside the body, so it's covered by mucosa. It doesn't have that epithelial layer. So when you're using harsh soaps or anything like that, it actually can dry the area out, also worsening the symptoms. So we touched on some of these. The rubber band ligation we talked about, Doppler guide ligation we also talked about. Infrared coagulation is also another option that works pretty well. It's somewhere in between there. Cryotherapy and injection sclerotherapy probably aren't performed as much nowadays. And then surgical option we talked about. So there is a modified hemorrhoidectomy where they have a staple hemorrhoidopexy. So that's what that device is on the right-hand side there. But it's the same principle where they're cutting out tissue, and basically that they're using a circular staple there to try and cut it off. So still kind of some of the same issues as far as recovery, painful recovery goes. And so why is this important? So we kind of touched on the demographics, but why is it even, this goes into a little bit more detail. So 50%, more than half Americans will suffer from hemorrhoids by the age of 50. So that's a huge chunk of our population. And of those patients, up to 49% who have had treatment will have recurrence of symptoms. And that's kind of what I touched on with rubber band ligation. So where did we get to where we are today? Like, how did we get here? So first embolizations were in the setting of GI bleeding were done decades ago. However, for rectal bleeding in the acute setting, there's a Dr. Vincent Vidal in France who described this novel technique for superior rectal artery embolization for hemorrhoids. The first prospective study was done in 2018. There's since been, now it's about 16 studies, clinical trials. Success rates are around 80% when you take all comers of all the studies, and that's even on the earlier days. I'll say for us, we published the largest data set of over 275 patients, and our success rates are around 94% primary success rate, with a recurrence rate of less than 10%, probably somewhere around 5 to 7%. And we opened our center here in Northern Virginia, comprehensive interventional radiology and GI practice dedicated to treating hemorrhoids in Northern Virginia back in 2021. This is just kind of what I mentioned in the beginning. So yeah, we received an award or it was for American College of Gastroenterology in Vancouver in 2023 for outstanding research related to hemorrhoid artery embolization. And then this past March, in our society, the Society of Interventional Radiology, we received Abstract of the Year for our long-term outcomes of 221 patients for hemorrhoidal artery embolization. So this concept, I kind of alluded to it earlier, is where you basically block off these abnormal blood vessels that form. So screen right is a demonstration of what we see. So this is the radiology component of what we see when we're doing live X-ray or fluoroscopy. We see these large, tortuous, abnormal blood vessels. They should be tapered down, just like how branches on a tree taper down and get fine and look like almost like a piece of hair. But as you can see here, these are enlarged and tortuous, and if you were to put measure the pressure in them, they would be higher than what they should be. So the concept came from Doppler guided ligation, where they were treating these blood vessels and getting great results. But instead of going up the rectum to do that, we're going from inside the body and using the blood vessels as a highway to get there. So this is that corpus cavernosum recti and these 3 tiers of blood vessels that I mentioned. So one other thing to point out is that this procedure predominantly treats internal hemorrhoids. Now, patients oftentimes can have internal and external hemorrhoids. So the difference between internal hemorrhoids is where they arise. So they arise above that dentate line, which is that middle dot, those middle dots right there. External hemorrhoids are going to arise from the skin. Now, reason why we don't primarily treat the external hemorrhoids with this type of treatment is because the blood vessel that goes there is the inferior rectal artery, which also supplies the skin. And you wouldn't necessarily want to treat that way because it can cause issues with the type of wound healings. But you can see if you treat anything from up above, you have robust collateral blood flow. So by treating only the abnormal ones, you'll still have enough blood flow where there's no issues with any type of ischemia or cutting off too much blood supply. So this is kind of a picture of that. So this is what we kind of see when we're doing the case in the lab with contrast dye and live X-ray. So who's a candidate? I kind of alluded to it earlier in the presentation, but really we can treat anywhere from grade 1 to grade 4. We typically don't treat grade 4 because they're usually better off with surgery, but there's often times where patients can't have surgery because they're on blood thinners or their heart and lungs can't handle surgery. So they can still come to us. But I would say the ideal candidate is going to be somewhere between grade 1 and grade 3. Now, what we've noticed with all comers is that, go back a slide here. What we notice with all comers is you get improvement in size of the hemorrhoids or prolapse, bleeding, pain, discomfort, all the symptoms, itching, all the symptoms associated with hemorrhoids, regardless of the grade. So how is it performed? It's just a little cartoon of how we do this, but essentially we're going to go through the blood vessel at the top of the leg, use a catheter, which is about the size of a long, thin piece of spaghetti. And through that catheter, we put an even tinier catheter. We'll take pictures along the way, identify the abnormal blood vessels that go down to typically go down to the hemorrhoidal tissue, find the abnormal ones, administer tiny microscopic plastic beads made of this medical grade plastic, and then behind it a microcoil, which is just on the order of a couple millimeters big. They don't shrink down in real time like that, but they do shrink. And then once we're done, we take everything out. There's typically, we treat somewhere between 3 to 6 blood vessels in a single treatment. And that's not because there's 3 to 6 hemorrhoids. It's usually there's 3 to 6 blood vessels supplying the hemorrhoids. Now, it can be done through the groin or the wrist. Typically, we'll go through the groin. It's a shorter route there and easier angles. So day of the procedure, the way that it works is it's a day procedure. So come to our office, go home the same day, change into a gown, would start an IV, and then would administer sedation medication. So patients will be in a twilight sleep. Once they're nice and comfortable, we'll start the procedure. So like in that cartoon, we go through the blood vessel at the top of the leg. They may or may not feel one tiny pinch from the numbing medicine. After that, the procedure is painless. We then use those catheters to go to the blood vessels and slow down the blood flow. When we're done, we'll take the catheters out, close the tiny hole that we made to get in the blood vessel with a tiny stitch. Stitch is about 1 millimeter big. Do not need to come back to get taken out. The body's going to incorporate it. They'll recover with us for 2 hours to let some of the sedation wear off. And then that stitch just set in, 2 hours up, walks out of the office the same day. Just can't drive because that's sedation. So all in all, they're in the office for about 3.5 hours. You get here about an hour before. Procedure itself takes about 30 minutes, and then the recovery is about 2 hours. Typically, there's not much pain at all afterwards. Some patients with rather large hemorrhoids may feel some fullness and discomfort, which is usually just relieved with over-the-counter NSAIDs like ibuprofen, Motrin, Aleve, what have you. We will do a follow-up at 1 month, 4 months, and then 12 months after the procedure. But symptomatic improvement will be noticed probably within the first 2 to 3 weeks. Symptoms like bleeding, pain, discomfort will improve at that point. Size of the hemorrhoids or prolapse will take the longest to improve. It can take weeks to months. It's dependent on a variety of factors, including there's elasticity of the tissue, healing properties, but things that are in patient's control are basically avoiding those things that can cause hemorrhoids in the first place, especially in that first month. If you can do that in that first month, you'll do really, really well. Common questions: how long does the procedure last, and is it painful? Like I said, it's anywhere from 20 to 90 minutes, and that's basically based off of patient anatomy, which you can't control and you won't know until you get in there. But vast majority of patients land somewhere between 30 and 60 minutes. What does the recovery process entail? Really, you're going to feel like your normal self. The only thing we ask is no strenuous activity or heavy lifting for 5 days, really just to let that stitch heal up. Is there anything inserted into the anus? No, nothing up the rectum, no bowel prep or anything like that. Everything is through the blood vessel. When will I start seeing results? So that's that 2 to 4 week mark. You'll notice improvement. We'll follow up at 1 month, make sure you're improving the way we expect. And then we'll also follow up at 4 months. Probably reach kind of whatever your new steady state would be when it comes to the size of the hemorrhoids by then. It's probably around 3 to 6 months, but we'll follow you at 4 months and then 12 months. And that's just over the phone unless there's a reason to bring in. How effective is the procedure and how long does it last? So up to 94% primary success rate. Recurrence rate at a year is going to be less than 10%, about 5 to 7%. There's no reason why this couldn't continue to last. Now, same thing with hemorrhoidectomy or any of the other procedures. If the issues that cause the hemorrhoids in the first place reoccur, you can have more hemorrhoids form, but there's no reason to say that this wouldn't be a durable effect that wouldn't continue to last. Okay. So that's all I have for the presentation. I'll leave this up here. This is my contact information, our office number, our email information. And let me just kind of go through and see if there's anything here in the chat. How do you know if you have internal or external hemorrhoids? That's a great question. You may not know yourself because you can have internal hemorrhoids that protrude out. So if you ever had a colonoscopy, they'd be able to tell you. If you ever saw your gastroenterologist, they'd be able to tell you. But honestly, if you have any doubt, you set up a consult with us. If you hadn't had any of those exams, we'd bring you in and we'd do an exam, and I'll be able to tell you exactly what you have. And how do you know if you have only internal hemorrhoids? One thing I want to clarify is that even though this procedure doesn't primarily treat external hemorrhoids, when we do treat the internal hemorrhoids, you do see typically improvement in the external hemorrhoids. It's just not a treatment primarily for the external hemorrhoids, if that makes sense. So the internal hemorrhoids will probably improve significantly, about 90%. And then the external hemorrhoids may improve 30, 40%. What is your relationship with Gastro Health? So it's a partnership. So I'm basically an interventional radiologist who works for Gastro Health, but we have gastroenterologists who offer rubber band ligation. We have docs who will offer hemorrhoidectomy, offer IRC. This is just one of the treatments that are offered through Gastro Health. Our office is located in Falls Church, Virginia. Let's see. Any issues if I'm on blood thinners? So it depends on what the blood thinner is. Most patients will ask just for the procedure, like if you're on Eliquis or Xarelto, to hold the blood thinners for 2 days, Coumadin or warfarin for 5 days. But if a patient cannot come off, like I talked about those non-surgical candidates, there are circumstances where we would allow them to continue, especially if it's something like Plavix and you had a heart stent or aspirin. Those things we could get past. Okay. What is the track record for body rejection of microballs and the thin coils left in the artery? We've been using these materials for decades. They're completely innate. They're not going to cause any issues. Now, in other parts of the body, if you were to do this, the one risk that you have is that they go somewhere where you don't intend. But these are kind of dead-end arteries, so that risk really isn't there. The coils are super soft. They're not very magnetic. You can undergo an MRI afterwards. They're not going to set off any metal detectors. You're not going to know that they're there, aside from the symptoms will improve. If hemorrhoids are not protruding, what symptoms will send you to the doctor? So symptoms like bleeding, pain, discomfort, itching, those are symptoms that typically occur when it's not prolapsed. So that's usually what we'll send them. I have an internal hemorrhoid but suffer from AVMs. Am I a candidate? So it depends. So we would probably have to, that's a little bit more of a intricate question there, but we probably have to review whatever imaging you had and what type of AVMs you have, but it shouldn't be an issue. If it's, I mean, just because you have a history of AVMs doesn't mean that you don't have run-of-the-mill internal hemorrhoids. So you typically, you could be a candidate. So I would definitely advise you to set up for a consult here. What's the best thing to do if it's external hemorrhoids? So if it's primarily external hemorrhoids, I would say at least try with conservative management first. But the only definitive way to get rid of the external hemorrhoids would be surgery or hemorrhoidectomy. This is so Eliquis. Yeah, Eliquis would be 48 hours before the procedure. Any recommendations on lifestyle and food choices after age 50? So when it comes to hemorrhoids and like healthy bowel habits, there's no one size fits all. I would say that eating a lot of fiber, eating a well-rounded diet would be helpful. Avoiding simple starchy carbohydrates if you're constipated, like breads, pastas, rice, what have you. Not saying to not eat it at all, but knowing what can kind of slow you down and constipate you would be best. Lots of water is always good. Okay, another worried that silicone and breast implants was deemed safe, but leaks as additional surgeries. Yeah, so that's a little bit different because that's caused mesis, and those leaks were basically or ruptured implants. It's more of a cosmesis thing. It's not necessarily the body, it would cause the body necessarily harm. But yeah, that's a great point. But we've been using this just as long, if not longer. What is the name of your office? So it's Hemorrhoid Centers or IR Centers in Falls Church, Virginia. Does taking supplements that increase nitric oxide levels affect hemorrhoids? I mean, I haven't seen any literature that says that it does. In theory, if you have uncontrolled hypertension, if you have hemorrhoids, it can make the symptoms worse, but it doesn't necessarily cause the hemorrhoids. Is this covered by Medicare? Yeah, so it's typically covered by most insurances and covered by Medicare. We have a team that will work in the back end. So you'll know what, if anything, you would owe before you would ever go for the procedure. If I have prolapse, but I'm eating a lot of fiber, I have no bleeding or pain, should I still get an intervention? So I think so. That's kind of, so some of these things are personal preference, right? If it's really bothersome to you and you think your lifestyle would be significantly different if you had it treated, then I would say yeah, because the drawback or the side effect profile or risk profile is so small. I have Crohn's and suffer from constipation. I have hemorrhoids, no bleeding but pain. So Crohn's disease or ulcerative colitis or any of the irritable bowel diseases, this actually is a good option compared to some of the others because it's doing surgery in that area where it's chronically inflamed is not always a great option. So people with Crohn's or ulcerative colitis can be good candidates. Now, I would say if you're still suffering from constipation, it might be ideal to kind of try and get that under control a little bit more before going for the procedure. Because I think we could help you from where you are right now, but if that continues on, there's a chance of recurring. But that's with any procedure, any surgery that you have. Should I have a colonoscopy prior to seeing you? So if bleeding is your symptom, or one of your symptoms, and you're of the age would recommend a colonoscopy. I would recommend you get a colonoscopy, but it's not a prerequisite to have it before the consult or even before the procedure. You also mentioned about pushing a hemorrhoid back in. Can I do that, or should I have my gastroenterologist do that? If you're comfortable doing it, you can do it. People do it all the time, sometimes tissue paper. But if you're not comfortable, obviously don't do that. Sorry, I joined late to the meeting. Can you please explain what is the new procedure to treat hemorrhoids? So it's hemorrhoid artery embolization. All this is going to be recorded and it can be sent out. So if you want to rewatch the presentation, also, if you just Google search my name, I have a couple podcasts on this topic, or any of my partners, they have talks on this as well. If a consult is scheduled and there are no symptoms, are you still able to tell if the hemorrhoids are internal or internal? In-person exam, I'd be able to tell. Do you need to see a colorectal surgeon about other procedures before pursuing this method? No, not necessarily. What are the possible side effects? Is fecal incontinence. So yeah, fecal incontinence, albeit rare, can be a side effect with surgery, but it's not a side effect with this procedure. Thank you for sharing this information. We watched it. Yes, you can watch the replay. They will send that out. Wow, this is a great group. A lot of awesome questions and a lot of attendees. So if no other questions, or I don't know if any of my colleagues want to chime in with anything. See. Polyethylene glycol. You can, yeah, it's as long if that's keeping you regular, that's okay. Yeah, so you can schedule a consult directly with us if you want to see if you're a candidate. You can schedule with the other gastro health docs too, and they may send you our way. But either way, we work in the whole same system. So if you see one of us, all your information will be in our chart. Well, I thank you all for joining. I hope this was helpful. We're here to serve the community. We do this procedure here in Northern Virginia. We have a center also in Florida, and we're opening other centers in the United States. We understand that this is kind of a disease process that there aren't really, there are limited treatment options, and some of them are more extreme. Most people, they're not as palatable for. And this really serves a good purpose here. So I think we can help a lot of patients out there with this procedure. My information's up here. Happy to help in any way that I can. And if no other questions, please reach out to us. Thank you, guys. Good night.
Thank you.